Okay, I think we'll get started because we only have an hour. We have a lot to cover, and the rate of entry is slowing down a little bit. Welcome, everybody, to our Alcohol, Tobacco, and Other Drugs Integrated Behavioral Health Spotlight. My name is Kathy Gorash. We will be talking today about insights into building an integrated behavioral health model, of which there are a variety of models, and we're going to get the specific perspectives from HRSA and SAMHSA in terms of the work that they're doing through their programs. Our presenters today are Commander Jayne Berube and Commander Nicole Pascua from HRSA and SAMHSA respectively. So we will have, they will each present, and then we'll do some Q&A at the end. In terms of why we're here, it would be helpful if you get a chance to put in the chat how you heard about this session, because we did a lot of promotion this time, and we want to know what works best. We also, you see a description here of our section, but also in what our IBH committee is. We have taken a broad definition to be able, primarily to be able to get abstracts for the annual meeting and to touch on all the great work that everyone's doing. Our presenters are, as I mentioned, Commander Berube and Commander Pascua from HRSA and SAMHSA, and their portfolio is here, and it's also, I mean, their bio is here, and it is also on the flyer that we use to promote. I am really glad that so many people are interested in this topic today. We've been trying to address integrated behavioral health within our ATOD section, and we are doing these spotlights or webinars essentially to shine a light on this growing and needed area. We have several oral sessions and a couple of posters sessions, so 20 lots of people working in the field, including many sections in APHA, particularly predominantly in mental health, but throughout APHA, 10 sections or so, if you were to look at integrated behavioral health. So today, to get started, we'll get guidance from the two major funders of the IBH programs in this country, and they'll talk about what their programs are. And so for that, I will turn to Commander Jayne Berube to share with us what HRSA is doing.
Okay, great. Thank you. Just one moment while I pull up my slides. Alrighty, hope you all can see my slides. Yes. Okay, great. Again, so I am Commander Jayne Berube. I am the team lead for the Care Integration and Workforce team here within the Office of Quality Improvement within the Bureau of Primary Health Care here at the Health Resources and Services Administration. And I want to say thank you again for the opportunity to share what our health centers are doing in the space of integrated behavioral health. So from my presentation, I'll share a bit of information on the health center program, our behavioral health and substance use disorder uniform data system, or our UDS data that we from all of our health centers. I'll provide some information on our technical assistant, as well as some of the funding opportunities that we've provided to support health center integration of behavioral health. A bit about the health center program. The health center program and our health centers receive federal grant funding to improve the health of underserved populations. To achieve this, health centers serve high need areas provide comprehensive primary care and enabling services, collaborate with other community providers, are patient-directed, do not turn patients away, and meet performance and accountability requirements, including our annual behavioral health and substance use disorder UDS measures, which I'll share in just a few slides. The health center program has 1,400 health centers, which run more than 15,500 service sites. They are in all U.S. states, territories, and the District of Columbia. You can find our health centers in cities, rural areas, and everywhere in between. We provide high-quality care to more than 31 million patients across the country, including 1 in 8 children. 90% of our health center patients of known income are living at or below 200% of the poverty line. Nearly 25 million of our patients are uninsured, Medicaid or Medicare patients, and we also serve 1.1 million patients at our school-based health center sites. And so the integration of behavioral health services at our health centers is important to HRSA and to BIPIC, as our health center patients are at higher risk of mental disorders because of greater exposure and vulnerability to unfavorable social, economic, and environmental circumstances interrelated with race, ethnicity, and gender disparities. Mental health and many mental disorders are shaped to a great extent by the social, economic, and physical environments in which people live. Integrated behavioral health is an administration top priority as more people turn to their primary care providers when they are struggling with mental health or substance use disorder. We know that the integration goes beyond co-locating primary care and behavioral health care. True integration enables providers across disciplines or the entire team to screen, assess, and to treat patients with patient-centered care. And our health centers work towards these goals every day, providing mental health services to approximately 2.8 million patients annually. This slide shows our 2023 behavioral health and UDS data, where health centers continue to meet the increased demand for mental health services since 2020 by providing screenings and other mental health services. 98% of our 1,400 health centers provide mental health services. 72% of our health centers provided MOUD, and 52% of health centers provided SUD services in 2023. We serve 2.8 million patients seeking mental health services from a dedicated mental health provider. In addition, 72% of our patients over the age of 12 were screened for depression and received a follow-up plan, if appropriate. And here in the bar graph, you can also see the steady increase in mental health visits since 2020. Health centers also continue to address the increased need for substance use disorder services nationwide by increasing access to medications for opioid use disorder services. In 2023, 136 additional health centers provided MOUD services, representing a 16% increase from 2020. 25,950 additional patients received MOUD services, and 4,454 additional providers were eligible to provide MOUD since 2020. And due to the retirement of the data waiver, this measure changed from health centers with providers with a data waiver in 2022 to health centers with providers who treat opioid use disorders with medications approved by the FDA for this indication. Also from our 2023 UDS data, as we look at our health centers workforce in 2023, health centers employed over 20,000 behavioral health full-time equivalents, further supporting the integration of behavioral health in primary care. To promote and support our health centers with their integration of behavioral health, we provide a very large technical assistance contract and services to all HRSA-supported health centers. The goal of our technical assistance is to provide innovative and timely TA that meets the health center's unique needs, to support our behavioral health and substance use disorder UDS measures, which I just shared. The TA also supports increased engagement and ongoing quality improvement as well as we provide continuing education credits for the majority of our TA events. Some of our TA topics include opioid use disorder, pediatric mental health, pregnancy and substance use disorder, which are our administration priorities, as well as we also focus on billing and coding, social determinants of health and health equity, behavioral health, and SUD, workforce well-being and retention strategies. We know that workforce is a huge issue across all of our health centers. And given that our health centers are sort of on a spectrum of their integration efforts, we deliver the TA through a variety of TA modalities that include virtual and on-site visits. We do one-on-one coaching or mentorship type sessions. We have webinars, communities of practice, focus groups. We've done several research briefs on integrated behavioral health. And just this summer, we had 65 staff across our health centers representing both behavioral health and primary care who attended an in-person training here at HRSA. Sorry. In addition to our UDS measures, we also look at the frequently requested TA topic areas requested by our health center. This gives us a bit of a pulse of what's going on at our health centers and what the areas of need are for our health centers. And these here are our most frequently requested areas for additional support from our health centers. So those include effective provision of brief, evidence-based billable behavioral health interventions, sustainably implementing and/or enhancing an integrated care model, documentation, billing, and coding for integrated care. The documentation, billing, we get a huge amount of interest from our health centers who want to learn more about that. Developing effective integrated care workflows, primary care and behavioral health collaboration and coordination to effectively treat chronic comorbid conditions, generating buy-in for effective systems level integration, normalizing behavioral health conditions and patient services in primary care, effective interventions for maternal and pediatric behavioral health, and providing trauma-informed services in primary care and integrated care settings. So again, these are our most frequently requested TA topic areas from our health centers. We also work with our primary care associations to support integrated behavioral health. Our PCAs work with health centers, providing care at schools to incorporate behavioral health services. Our PCAs also work with health centers to support behavioral health and substance use disorder UDS measures. And they also support peer learning teams that are focused on clinical training, integration strategies, trauma-informed care, as well as integrating behavioral health through practice change. HRSA invests in behavioral health. We are excited to announce that we recently awarded $240 million in funding to 400 community health centers that provide primary care to more than 10 million patients. Funds will be used to increase access to mental health services and substance use disorder services by starting or expanding these services. And the average award is around $600,000 over 2 years, which will be used to address barriers to receiving behavioral health care, such as gaps in available services, workforce shortages, and stigma and discrimination. Awardees will also partner with other organizations to help meet the needs of patients with complex behavioral health or health-related social needs. And we are excited that 77% of our awardees plan to use the funds to provide mental health, substance use disorder, or MOUD services for the first time. So we are anticipating a lot of technical assistance over the upcoming years. Additionally, we've also invested in school-based services. We recently awarded the 2023 school-based service expansion funding, which will expand access to primary healthcare services with a focus on mental health services through service delivery sites at schools. So recently, again, 2023, we just awarded 25 million and 77 awards to support integrated behavioral health, specifically looking at the delivery of behavioral health at our school-based sites. And that is a summary of the areas that HRSA and BIPIC are working on to support integrated behavioral health. So I will kick it back over.
Thank you for so much for what you had to say and what you're doing at HRSA. I think what we'll do is, because we have a fair amount of people and probably questions, is that we'll just go into our second presentation from SAMHSA and then take questions from everyone and see what we have. So with that, I'd like to turn it over to Commander Pascua and from SAMHSA to tell us about what you guys are up to.
All right, perfect. Thank you so much, Kathy. For all of you on the line, my name is Commander Nicole Pascua, and I am the Chief of the Comprehensive Services and Integration Branch within the Division of Community Behavioral Health within the Center for Mental Health Services at SAMHSA. So I want to say thank you to Kathy and the organizers of this meeting for inviting SAMHSA to present on our integrated care programming and to very briefly, provide some information on the components that go into our funding or formulating our strategies for increasing and enhancing the uptake of primary and behavioral health care across the nation. So next slide, please. So I wanted to start off by actually letting or informing all of you about our mission as an agency, because I think, you know, SAMHSA is a smaller agency within the HHS family, even smaller than HRSA. We're like strong but mighty. So as you can see from the slide, SAMHSA's mission is to lead public health and service delivery efforts that promote health, prevent substance misuse, and provide treatments and supports to foster recovery while ensuring equitable access. And we do this through a variety of different ways or different activities, such as grants or other funding mechanisms, technical assistance related to a variety of treatment modalities or models, as well as data and surveillance and partnership engagement, both across federal agencies and externally with state and local entities. So next slide, please. So in brief, for all of you across the nation on this presentation, SAMHSA has 3 main centers as well as supporting offices, but the centers are the ones I like to say that are kind of, you know, the muscle, right? So there's 4. Center for Mental Health Services, where I'm situated, leads federal efforts to promote the prevention and treatment of mental disorders. And Congress created actually CMHS to bring new hope to adults who have serious mental illness and children with emotional disorders. And then there's also the Center for Substance Abuse Prevention, CSAP, which helps to improve behavioral health through evidence-based prevention approaches. And then there's CSAT, which is the Center for Substance Abuse Treatment, which promotes community-based substance use disorder treatment and recovery support services for individuals and families in every community across the nation. And then we have CBISC, which is the Center for Behavioral Health Statistics and Quality. So for all of you who you know, apply for grant funding or even write academic papers or even teach, you may have used some of our statistics from CBISC, which leads the federal government in behavioral health data and research. Okay, next slide, please. So I also wanted to show you our strategic plan wheel, which actually mentions the integration of primary behavioral health care because it is of utmost importance and a strategic priority for SAMHSA. As you can see, it contains 5 priority areas. So I already mentioned integrating behavioral and physical health care. There's also strengthening the behavioral health workforce, We also focus on preventing substance use and overdose, also enhancing access to suicide prevention and mental health services, as well as promoting resilience and emotional health for children, youth, and family. And some of the guiding principles include equity, trauma-informed approaches, recovery, commitment to data and evidence as well. And so I say all of this to say is that the integration of primary behavioral health care is broad, but very specific. And we try to do a justice by incorporating all of these elements, not just our strategic priority areas into some of our integrated grant programming, but also the guiding principles as well. So next slide, please. So this slide further illustrates the ongoing bidirectional communication and engagement that we have with our federal partners in Congress. But I would really be remiss if I did not make special note of our collaboration with our other non-federal partners and other community organizations, such as the American Psychiatric Association, the National Council on Mental Wellbeing, the American Psychological Association, to name a few, as well as APHA. That really helps to partner with us in terms of ensuring that our programming is timely, but also meets the needs of the nation. And it's through our partners, our wide variety of partners and stakeholders, that their extensive feedback and call for action that legislation has been passed, which was attuned to improving our mental health care framework in the United States. And next slide, please. And so one way that we actually see this happening is at the HHS level, the broader level of the Department of Health and Human Services. And one example is SAMHSA's participation in the Behavioral Health Coordinating Council, or the BHCC. And I don't know if you're familiar with this or have read about this. So it was actually formed under our HHS secretary when he engaged in a national tour to speak to providers about the behavioral health care challenges that they faced. And as a result of this tour, the BHCC was formed and tasked with operationalizing that feedback. And more specifically, one subcommittee that was formed was specifically on behavioral and physical health integration, with the goals of improving equitable access to integrated physical and behavioral healthcare services, supporting the development of a diverse health workforce for integrated behavioral and physical health teams, as well as leveraging technology-enabled solutions and increasing research and evaluation related to models of care. And all of you can look this up, but there was a written product from the BHCC called the Roadmap for Behavioral Health Integration, which actually aims to ensure that the full spectrum of behavioral health care is integrated into healthcare systems, social service, and early childhood systems. Okay, so next slide, please. So moving more specifically into SAMHSA, one way that SAMHSA has promoted the increase of primary and behavioral health care, the integration of it, is through our first grant program that SAMHSA developed. And it was called the Primary and Behavioral Health Care Integration Program, or PBHCI, which was actually authorized under Section 520A of the Public Health Service. So our first cohort of this was launched in 2009. And in total, 213 grants were awarded across the nation across 9 cohorts. So as you can see from the slide, the purpose of the grant program was for community organizations to improve the health status of adults with serious mental illness, or SMI, including those with co-occurring substance use disorders who also had comorbid physical health conditions and chronic diseases, or who were at risk for developing them. So overall, the grantees were also allowed to provide evidence-based wellness and health promotion programming, including education around tobacco cessation, nutrition and exercise, and chronic disease self-management. So that program sunsetted altogether in 2019. Next slide, please. So our next integration programming that took the place of PBHCI, which sunsetted in 2019, was or is the Promoting Integration of Primary Behavioral Health Care, or PIPIC for short. So this program started in 2017 and is still active today. But one thing you should know is that this program is statutorily limited to states or state entities, such as a mental health authority, or a single state agency for substance abuse services, or even like the state health department or state Medicaid agency. And it's the states who then work with or identify community providers to deliver the services. And the thinking is that with state leadership, the state can be invested in helping community organizations to build integrated care programming that actually does the good work that's needed in the communities. And it also provides that leadership needed at the state level. So altogether, the purpose of the grant program is to promote full integration and collaboration in clinical practice between physical and behavioral health care, to also support the improvement of integrated care models, and then also to promote the implementation and improvement of bidirectional integrated care services, which not only includes evidence-based or evidence-informed screening, assessment, diagnosis, prevention, and treatment, but also attunement for co-occurring physical health conditions and chronic diseases. Okay, so next slide, please. So with the PIPIC program, there must be a focus on special populations, and the special populations that are listed on the slide are still actually written into statute. So our providers must identify a specific population on this list right here. So it can be adults with SMI, or co-occurring mental health illness and physical health conditions or chronic disease, children with SED who have co-occurring physical health conditions or chronic disease, or individuals with substance use disorder, or individuals with co-occurring mental and substance use disorder. But overall, the purpose of PIPIC is really to promote collaboration and integration of clinical practice across behavioral and behavioral and physical health care. Okay. So next slide, please. So starting in FY 2023, the PIPIC program evolved due to updates within statute. And more specifically, there was mention of a specific model that that some of our projects needed to take up, and that was the collaborative care model. And then, so for example, we broke the PIPIC program into two tracks. The first is the traditional model, which is the comprehensive integration in community mental health centers or community health centers, and the other is the collaborative care model in primary care settings. And then most recently for FY24, which just actually passed, we're actually in federal fiscal year 2025, we recently awarded 11 new grants across the two programs that you see on the right-hand side in the box. So we're excited to kick off those programs and get them underway. Okay, so next slide, please. So since 2017, we have awarded 55 awards across 37 states, including the District of Columbia, Puerto Rico, and American Samoa, and at least one award has been made to each of the 10 HHS regions. But currently we have 32 active grants, and altogether our grants have served at least 54,000 clients in their PIPIC programming. Okay, so next slide, please. So these are just a few metrics that I pulled from our PIPIC program. So please know that in our grant program, we do require grantees to collect national outcomes measures, NOMS data on the clients who have been served. So for example, what's not here on the slide actually is that of those clients who are served, about 63% of clients had a mental health diagnosis. 25% had a co-occurring diagnosis, and about 12% had a substance use disorder diagnosis. And of the mental health diagnoses, anxiety, depression, manic disorder, or bipolar were the highest identified among the client population. And then within those who were identified with a substance use disorder, the highest diagnoses were opioid use, alcohol use, and then cannabis use. But just wanting to point out a few statistics on this slide. So at 6-month reassessment of client participation in PIPP programming, there was a 75% decrease of clients reporting any hospitalization for detox or substance use within the last 30 days of that reassessment. Additionally, there was a 46% decrease of clients reporting any hospitalization for mental health issues within the last 30 days. And then there was a decrease of 45% of clients who reported any emergency room visits for mental health issues within the last 30 days. Okay. So next slide, please. And then here's a little bit more information about, there was a 25% decrease of clients who reported being bothered by psychological or emotional problems, a decrease of 36% of those indicating being depressed or nothing to feel happy about. And then there was a decrease in worthlessness or feelings of hopelessness or feelings of being restless or fidgety. Okay, so next slide, please. So in addition to direct grants to states, we also provide a grant funds to establish a Center of Excellence for Integrated Health Solutions. So this is a technical assistance and training center that is open to the public, and they provide training in the forms of webinars, resource tools, learning eco communities involving topically focused issues that support the integration of primary and behavioral health care. And I believe at the end of this presentation, there is a slide that has links to our current Center of Excellence. Okay, so next slide. So in brief, that Center of Excellence provides a lot of resource and training information, but I do want to just highlight a few that may be of interest to all of you. And I should also say that those webinars are free, and if you do sign up, you can get access to the recordings on demand. Okay, so a few past trainings involve topics related to promoting pediatric well-being through integrated care, enhancing equity in maternal health outcomes for women of color, or measurement-informed care in behavioral health and improving integrated care financing. And of special note, I think it's also helpful for you to know that the TA Center also developed a comprehensive healthcare integration framework, which helps organizations guide the implementation of integration of physical health and behavioral health. And they did so along 8 domains, and you can pull the guidance document for yourself. And so those domains help organizations to determine their level of integratedness and how far they need to go in terms of being fully integrated or even bidirectional. And some of those domains include multidisciplinary teamwork, financial sustainability, self-management support, as well as screening, referral, and follow-up. And then also, in brief, another tool that could be of interest to all of you is that they also developed an integrated care decision support tool. And this tool was designed in partnership with another organization, which is aimed to help provider organizations sustainably finance their integrated care in environments where enhanced reimbursement or prospective payment system funding is not yet available. So it also helps providers to estimate Medicare and Medicaid revenue across prominent integrated care services and how to finance them more effectively when providing mental health, substance use treatment, and primary care. And then in addition, for this tool, it also includes information on specific billing codes, service types, professional discipline coverage, and documentation. Okay, so next slide, please. So SAMHSA also has a variety of other initiatives that go hand in hand with the integration of primary and behavioral health care. So these are just a few selected items, but we do have much more, and you can check them out on our SAMHSA website. So for example, and I don't know if you many of you are familiar with or have heard of the Certified Community Behavioral Health Clinics, CCBHC model. We do provide extensive grant support across the nation for community providers to implement CCBHCs. One of the 9 core services is primary care screening and monitoring. That doesn't speak in and of itself to full integrated care, but there are many grantees who actually do more than that. And in fact, many of our PIPIC state grantees select providers to deliver PIPIC services who are also CCBHCs in and of themselves. So we do have more information on the CCBHCs on our website and the locations of those CCBHCs. We also have grants for SBIRT, which, as you may know, SBIRT grants implement screening, brief intervention, and referral to treatment services for children, adults, and adolescents in primary and community health settings with a focus on screening for underage drinking, opioid use, and other substance use. We also have grants related to our Minority AIDS Initiative, which helps community organizations to reduce the co-occurring epidemics of HIV, hepatitis, and mental health disorder through accessible, evidence-based, and culturally appropriate mental and co-occurring disorder treatment that is integrated with HIV primary care and prevention services. And then last but not least, we have our PATH program, which falls kind of under the auspices of Homeless and Housing Resources. And our PATH program engages community providers in establishing pathways for those who are homeless to not only treat their mental health, but promotes referrals to follow-up services such as screening and diagnostic treatment, community mental health, substance use disorder treatment, and referrals for primary health care. And then next slide, please. And then last but not least, SAMHSA continues to engage in many activities that will promote integration. So we do have a PIPIC report to Congress that is due this year to report out on the outcomes of our PIPIC or integrated care programming. We do also intend to collect data from our collaborative care model grantees to ascertain how effective their PIPIC programming for the collaborative care model is going. We also are kicking off a new grant for our Center of Excellence for Integrated Health Solutions, which will also have a focus for the collaborative care model. And then we will also continue our ongoing collaboration with national and federal partners, such as HRSA, as well as ARC, which is the Agency for Healthcare Research and Quality. They themselves also has an integration academy, which is a national resource on providing information to clinicians, patients, and the nation in general on integrated care programming and training. Okay, so next slide. So here is our website. To please go ahead and check it out. We have a variety of practitioner resources, publications, as well as other information on technical and training assistance centers that are topically focused. So probably anything mental health that you can think of, we probably have a resource or additional information to expand your knowledge base or to provide it to your colleagues as well in the public health field. So with that, I will stop and I will turn it over to Kathy. Thank you.
Thank you so much, Nicole and Jane. Tons of information. I'm sure there was something there for everyone. Maybe some people are already funded by your agencies, didn't know about some of the other resources you were shared with us. So that is wonderful. We also have some resources from each of the agencies, although I saw that you had links on the bottom of some of your slides. But from HRSA, there's their main library, and then from SAMHSA, there is a series of links. But as Nicole said, on SAMHSA's website, there's more there. It's a very rich source of information from both agencies. And with that, I'd like to thank you in particular, but also see what questions people have for you. I know there were a few questions in the chat, the last I peeked, but Victoria is looking at that. So if you could return us back to the main screen and see what questions people have.
Sure. So first, we did get a couple questions about if we can share these slides with our attendees. Is that all right by the two of you?
Yes, no problem.
Okay, great. Wonderful.
We'll get those back out to you shortly.
Yeah, wonderful. And then Jane, there was a question about if you are working with CBOs or NGOs or student organizations. And if so, what do you do with them?
So for our technical assistance piece, we don't currently work with those organizations. It may be that our health centers are working with them, but I can't say that HRSA's Office of Quality Improvement is currently working with those organizations. I can say that with the rollout of the behavioral health services expansion, which I just shared that $240 million, when we capture some of the progress reports that come in from that funding opportunity, we'll get some more rich information on who some of the collaborators are that our health centers are working with.
Okay, great, thank you. Another question that just came in, are there any specific behavioral health primary care equity initiatives currently underway or expected in the future? I think this is for both of you.
We certainly factor equity into all of our technical assistance and our funding opportunities. Again, you know, our health centers serve underserved populations, so equity, social determinants of health, health equity are always themes that we continue to promote throughout our technical assistance and our overall focus of the health center program.
So same with SAMHSA. I had a slide with regards to our strategic plan, and equity is one of the guiding principles. If you ever have the occasion to look at our strategic plan, which is on the SAMHSA website, it does provide additional information on our efforts. But in addition to that, our grant funded opportunities specifically mention equity, as well as a focus on underserved populations. And also, in addition to that, we do ask, I believe it's on the majority of our grant funded opportunities, the notice of funding opportunities, that a requirement of our grantees is to actually have a disparity impact reduction plan to further look at their special populations, and then to drill down to see how we can reduce disparities and provide more equitable access to services through our grant funding. So yes.
Great. Thank you both for that. I have a couple questions too that came to me, but if anybody else has anything else, definitely jump in. So I'm a little bit curious. We've talked a little bit about primary care, mental health, behavioral health, that sort of integration. Have you received any requests, or do you fund any sort of opportunities that also support the integration of other services, whether that be like harm reduction or social services, or have you gotten any technical assistance requests in those regards?
I can say that for our technical assistance, we don't generally get a lot of requests for TA in those areas. It's primarily those top 9 focus areas, as well as our administration priorities. I can't really speak to those specifically.
Sure. Okay.
So our Technical Assistance and Training Center can develop trainings or information on those specific types of topics. However, some of our grant programming does allow for some of the grant funds to be allocated towards such things as harm reduction activities, referrals to like oral health care, psychosocial services, tobacco cessation. So yes, but it could be specific. It's specific to each program. And I can say specifically for HIPIC, there is not mention of harm reduction. However, there is mention of other allowable activities that go hand in hand with overall whole person care and wellness.
Great. Thank you. All right. What are you currently doing to support school-based mental health initiatives for undergraduates, faculty, and minority populations, if that is the case? And then do you accept unsolicited submissions?
So I can say for SAMHSA is that our grant funding opportunities are listed as part of our Notice of Funding Opportunities, NOFOs, and that is actually posted on our SAMHSA website, or you can look at the whole array of funding opportunities within the federal government at grants.gov. So with regards to initiatives for school-age children, or even a college age, there are SAMHSA grant programs that do have those specific age populations as an area of focus. I can't speak of any of them in particular, primarily because that's not kind of my bread and butter, but we do have programs focused on suicide prevention. Also, I want to say school-aged mental health for children. And then in addition to that, many of our grantees within the Center of Mental Health Services, such as CCBHC or even PIPIC, they have providers oftentimes that go into or partner with school-based systems to provide services within the school, but it's based on their partnerships that they have formulated, or that's part of their project plan.
Okay. Wonderful. Okay, I know we are kind of running down on time. So I think there's a couple more questions. Are there best practices published on your site for working with pregnant moms with substance use disorder?
So I would say from SAMHSA, yes, there are. If you go on our SAMHSA webpage, there is a link to publications. The other thing that you can look at in terms of our SAMHSA is that we have a list, a site for practitioner trainings, and there are several centers of excellence. One of them is our Center of Excellence for Integrated Health Solutions, and there is resources there, which you'll have a link. I think Kathy will send out the slides. So there are, since it's topically focused, I'm not necessarily the expert on everything that we may have about that, but we have a variety of different items.
And I would say for us, we've done webinars on the topics, but it's been more broadly, concepts in that area, but not so much a specific evidence-based program per se.
Sure. Great. Thank you. I think I have one more question, unless there's other things coming through. One question was around stigma, and if you have heard from grantees or have provided assistance to grantees related to stigma when treating patients with substance use disorders or other mental health conditions, co-occurring disorders. And if you've provided some technical assistance there, or what you were hearing from some of your grantees in this space around stigma.
So I would say, stigma around obtaining or getting treatment for substance use or mental health issues is still very prevalent across the nation and specifically within certain populations within the United States. And it's not kind of a one size fits all, like do this and stigma will go away. It's very nuanced. And most recently, I did speak to a grantee who said that they wanted to focus on rural mental health, specifically farmers, and to embed mental health services within primary care settings, primarily because of the stigma that many farmers feel that there is in terms of getting health. So instead, if they were to go to their primary care physician to get their mental health services, they could say, oh, I just went for a checkup versus I went for therapy. And the rationale behind it, apparently, according to this grantee, is that farming can be very competitive. And so if there's any inkling that, you may be ill or may be suffering from something that, they didn't want to have it be known that they needed mental health treatment. Which I thought was very interesting and something that I have never thought about before. But needless to say, I don't know if we have specific information to reduce the stigmatization of treatment, but I know at the community and provider level that it's still something that they struggle with, particularly in terms of getting clients, referrals, or clients who will voluntarily come in after they may have some kind of diagnosis of a mental health or behavioral health ailment.
Cool. Yeah. I live in a rural community myself, and so I feel that I practice that kind of on myself. Okay, with about 5 minutes left, Kathy, I just want to check in and see if there's anything else we need to cover. I know there's a couple questions here that we can follow up with folks on.
Yeah, I see that there's a couple more. Let me just shift gears for a moment and then we can go back if there's a question. But to thank everyone who's attended, because we're starting to get a little bit of a drop off, particularly our presenters and Natalia and Victoria for helping make this real and happen. But what I wanted to make sure everyone knows is that I hope you can get involved with our section or one that addresses some of these issues. The annual meeting's coming up in the end of October. Oh, we're October 1, the end of the month. And there's a whole lot of IBH sessions. We have a business meeting and our committee is meeting on Saturday of the meeting. So please join us, stay in touch. If you have any ideas for future spotlights related to this topic of IBH, please contact us at the address that's listed below, atodspotlight@gmail.com. And I think that's it for what I wanted to promote, other than let everyone know that looks like people heard from this far and wide, so it was good that we did a broad distribution. And there were a couple other questions, but we'll do our best. I don't know. Let's see, what time is it? We could go back to maybe one more. There was one on the SAMHSA's 8. I lost the chat. Let's see.
So I think so. There was a question about SAMHSA's 8 dimensions of wellness. I think we could probably find that on the website and send out to folks.
Yeah, so I think what Tasha Ellis is referring to is actually the Comprehensive Health Integration Framework that has 8 domains. It's actually part of our Center of Excellence for Integrated Health Solutions.
Okay.
And it's actually, there's a link in your slide deck for
Great.
resources. I put it there.
Okay. I think there's just a couple others. So someone brought up homelessness. Do any of your grants or programs opportunities engage with folks on mitigating homelessness? Because it's also a cause and an outcome of mental health and other behavioral health issues.
Yeah, so you're certainly correct. Actually, we do have quite a few programs that are aimed towards the homeless population. I would encourage you to actually go to our strategic plan on the SAMHSA website because it does mention several of our grant programs, including PATH, the one that I had mentioned. In addition, we do have, I don't want to call it a partnership, but an ongoing kind of collaboration and dialogue with HUD, the Department of Housing and Urban Development, to provide information to them with regards to our grants and our community providers that are available to their HUD coordinators in local communities, because one of the things that we heard that we found is that many of the concerns or issues that their clients, I don't know if they're clients or that they see among folks who are engaging in their services have to do with not just mental health but substance use disorders, but a large array of psychosocial issues that many of our grant providers could perhaps address or help mitigate, because many of our grant programs have therapists, have community health workers, have peer support specialists who can be attuned to those particular items that HUD recipients may be encountering. So that's actually one of the ways that we try to collaborate across agencies. So like, HUD, HRSA, ARC, and IMH as well. A variety of different ways. It's all part and parcel of just really moving the needle towards helping the nation and our local communities.
Oh, absolutely.
And I'd like to thank you. I'd like to just see, Jayne, if you had any final comments you'd like to add.
No, I just want to say thank you very much for the opportunity to share information on our health center program, our UDS measures, and our technical assistance. So thank you very much.
And it looks like people were very, did you have a final comment, Nicole?
No, I was waving. Bye.
Oh, waving. But it seemed like people in the comments were very appreciative of the information and definitely interested in those slides. So we'll get them out to everybody. And I think we're at time. So again, thank you, everyone, and hope to see you again at some of our activities.